Welcome back. We're up to item 142, Roman 1, the performance. Just before I bring the Deputy Chief Exec in, Jill, quick message for you, because we discussed it in the meeting this morning around the record keeping that we'll be doing for site visits, clinical visits, ward visits, etc. Jackie will be contacting you outside of this meeting to discuss the type of format that we'll be using. It's just for your information.
Thank you.
Deputy Chief Exec.
Thank you, Chair. So the report here in this format is an update actually on previous versions of the integrated performance report. We recognise there's more to do to make it truly integrated piece, which we're going to continue our work on, but also to consolidate the significant amount of data and information contained within a consolidated and targeted summary report in 3 A's. So it's a work in progress document for us at this stage. For this meeting, we're adopting a bit of an evolutionary approach, and my introduction won't repeat the key summary points contained within the report. Rather, I'll set out the issues we need to expand on to add value to the report through targeted updates from the relevant executive leads. So I'll just summarise how that will go. So the quality and safety section obviously is jointly owned by the medical director and chief nurse. And the board should note firstly that a detailed paper in respect of mortality was presented to the Quality and Safety Committee 2 weeks ago. And this provided information and data on the core hospital standardised mortality ratio and the summary hospital level mortality indicator that is presented within the IPR itself. The mortality steering group is overseeing ongoing work in this regard, and the quarterly report is referenced within the 3 A's report to the Quality and Safety Committee, also contained within these papers. There are a number of issues identified within this section, and I will in a moment hand over to my colleague Jackie as Chief Nurse to provide her update in respect of a number of items, including C. difficile, the safer staffing review and various other components of data that are in the pack. In respect to the operational performance section, the Chief Operating Officer has reported specifically on significant urgent care pressures within this report, as well as through various other routes, alongside updates on restoration and recovery and other access targets. The board has received additional information today related to stroke improvements through 2 different items on the agenda, so I won't reiterate the points there. I know that Kate, as Chief Operating Officer, would like to flag some additional points on RTT, urgent care and cancer referrals, and an item on breast care. So we will turn to that point in a moment. Within the people and organisational development section, the Director of People and OD will provide a further update and context to the board, including in respect of the medical and dental vacancies risk reported within the document, developing challenges associated with sickness and absence rates and our support for colleagues in this context, vaccination programme, and the point on core skills framework compliance. And then just my final point for a handover to Jackie is the key issues contained within the finance section of the IPR. They're clearly set out in the report and in the month 6 finance report contained in the reference pack. There is a further update, in particular in respect to the challenges faced for the second half of the financial year, in particular in respect of risk associated with the elective recovery fund and the determination and distribution of system allocations, and that will be referenced not only in the report from the Chair of the Finance Committee, but also I propose we defer further discussion to that section of the meeting and the half 2 planning items, so I'll return to those. That's my way of introduction, and then I'd like to hand over to Jackie.
Thank you very much. So I think I first wanted to start off by saying that the items in the integrated performance report are here, and we have been working. So I'd like to commend Lynn Wire on some of this work that we've been doing. We've now got all of these metrics in as part of our DARSI quality governance process. So they're in patient experience, patient safety or clinical effectiveness. So we've got them all into the right place now. What we need to do now is to hone some of these metrics so that they're more meaningful to the board and to make sure that that commentary is there. So that's what we're working on for this month. So I'm hoping that in the November board, you'll see something that's very different again. If I could just talk firstly about Clostridium difficile, just to say that we have reached our target of no more than 52 cases in the year. What we have done, and I've worked closely with, as the Director of Infection Prevention and Control, worked closely with the IPC team, and we've given a trajectory now to surgery and to medicine for the rest of the year of what we expect them to achieve. I think nationally there is a rise in cases of C. diff. A lot of that, as I probably mentioned last month, was around COVID and probably taking our foot off the antibiotic prescribing as we would normally do, and we're seeing some consequences of that. The other thing that I've done is I've put myself in to be the chair of the IPC committee, so that starts next week. So that's something that was really important. With regards to the pressure ulcers and ranging there, so the number of more serious grade pressure ulcers have stayed low, and so should they, because that is a reflection on the nursing care that's been provided. But what we want to do is to try and get some benchmark, and it's really hard benchmarking wise, but there is stuff out there, so we're going to look at the benchmarking and where we're up to. This captures all our pressure ulcers, so the ones that are in the community that come in, which are part of our care, as well as the hospital. I've asked for those to be divided out so I can see what is actually happening in our beds, because there's a link between the care of pressure ulcers but also with safe staffing. So have we got enough registered nurses who know what they should be doing to make sure that we're really following that? So that will hopefully, may not change for next month, but we will be working on that benchmarking, but we will do the extraction between community and the hospital for next time. So, and as you know, that's part of the RSP programme as part of the fundamentals of care, so that's in there as well. And we've set a trajectory for pressure ulcers as well. So Lynn Wyer's been leading on that for me as well. Falls, again, the same way we captured it as part of the RSP. What you're seeing here is natural variation. We were concerned about the number of patients who were in the hospital who didn't need to be around criteria to reside, and was that having a consequence of it? But it has dropped down this month without any different interventions. So I think it probably is natural variation. But we will keep an eye on that. And again, we're working with Mel Woolfall, who you met this morning, and Sarah Maguire, her opposite number in surgery, are leading those panels now. So we've got real operational leadership in there for where it counts. The other thing I wanted to mention was around the safe staffing stuff. These charts don't demonstrate what I want them to demonstrate, because we actually submit national data into a national system, and I don't, if I'm honest, don't really know where this is coming from. So that will change next month. We will show you something different. And then the final bit I wanted to bring up was around the patient safety incidents. So the best practice would be to be a high reporting, low harm organisation. So that we're reporting well and high is good. What we need to see is the numbers of moderate incidents and above start to come down, because our practices are changing and we're learning. So that's where we're going there. There is national benchmarking data on this through the NHSLA, and we're going to have that benchmarking next time, so that's going to change as well for you. And the final thing I wanted to mention was around serious incidents, and because there was a lot in the press last month about serious incidents, so I just wanted to let you know that we've got 36 SI investigations ongoing at the moment, and we have 60 working days to deal with these. We've got 10 that are overdue at the moment. 2 of them are HSIB, so the Hospital Safety Investigation Bureau, which does all the work around maternity. So 2 are outside our control there, and 1's another police investigation, which we can't incident. So we've got one that's already gone through the panel and waiting to be signed off, and 4 that are being closed subject to minor amendments. So I'm pleased with where we were, because this was not the position when we started this work in April. So we've really brought those number of SIs down that are outstanding. What we do need to get better at, and I think it's something we're still there with, is about reporting our SIs in a timely way. But they have improved. But we're making sure that our colleagues in the CCG and the regional office know that some of those are actually historical events that we've identified to our processes and have reported. So I don't want them to get mixed up about what late reporting means, because actually it might be timely reporting, but of a historical event. So I'll stop there, Chair. Thank you.
Thank you, Jackie. Colleagues, I'm just impressed with the you presented the report. I think that's the first thing I want to say. Clear, sequential, methodical. Thank you.
Yeah, thank you, Jackie. I'm really pleased to hear that we'll be getting more benchmarking data going forward, which I think the board knows in my short time here being a passion of mine. So I'm really great about that. And I suppose my question relates a little bit to that, because the C. diff stuff is obviously of concern for us. And we're only just over halfway through the year. But I want to know if you know, you may not, because obviously you talk about antibiotic prescribing changing, but I'm very aware with my day job that actually antibiotic prescribing has probably changed through COVID in the community.
Yeah.
So I'm wondering if there's been a significant increase in the number of people arriving in the hospital with C. diff, and also whether this is a national issue.
Yeah, I think it is a national issue, and I think it feels like you were listening into a conversation I was having yesterday with our head of infection prevention and control, because I've asked her to separate these out. Right. So they could have been our patients that went out into the community and then came back in with that within that time frame. So it becomes our issue, but there will be some that relate to the community prescribing. So I'm asking for separation out of that, and that will be going to the infection prevention and control committee.
Great. Okay. So we in future may actually get that highlighted if it is an issue.
Yeah.
Thank you.
Thank you. Thank you. Liz?
Thanks, Jackie. My question is more about the risks associated with the increase in also attendances, but also the number of, I'm trying to think of the word, how full the hospitals are at the moment. And is that having a knock-on effect on infections?
Yeah. So we've got a real sort of like perfect storm going on at the moment. So we've got our occupancy, and Kate may want to come in on this afterwards, but we're running at 98, 100% on our sites. We've got nosocomial infections, which is related to the COVID, so that we are, because we've got so many patients in, we perhaps haven't got that streaming of patients we'd like to. We've got norovirus in the community. We've got the hospital-acquired infections, which are always there, but I think we're seeing many of them. So, and we've got an estate that actually has not got enough single-side rooms for how you would want to manage this. So yeah, it is that perfect storm. And as rates rise, I think this week they're going down a little bit, but we've got to really watch that. But we've also got all the other patients that are coming in with non-elective patients that need our beds as well. So it's making sure that we can get that flow going in the organisation. But the big bit is, how do we get down to what the World Health Organization says is good bed occupancy, which is 85%, to stop the spread of infections between patients.
Thank you. No further comments, Jackie? Jackie, thank you for that report.
Just to take the additional points Kate wanted to make, Chair.
Thank you. And a perfect segue into one of the points I was wanting to raise, which was absolutely about the urgent care pressure we've got. All of our plans point towards delivery of that 85% occupancy, but we are having additional attendances and admissions. And I think we've talked before about the difficulties we've got with discharge at the back door, and you can see from the data in the pack that it's a deteriorating position. It is getting worse, with patients spending longer in ED and significant increases in number of 12 waits as a result. And this is a position which is reflected right across all the acute trusts in the ICS, so this is not just us. Just wanted to confirm that for those long waiters in ED, the teams do wrap care and attention around those patients, you know, particularly those longer waiters that may be in there overnight, so with beds, not trolleys, and making sure food and everything is there. However, clearly this is a position that we just cannot be carry on with all the way through the winter. I think it does feel like the pressures are unprecedented, and it is a mix of the COVID, the norovirus, all of those different infections, but then our non-electives and the super green patients we have for the elective recovery, together with ordinary green patients. So it is the teams do a fantastic job every day trying to cohort all those different streams of patients coming through what is, as Jackie says, actually, particularly at Lancaster, quite awkward site configuration to do that. However, the goal remains to get that occupancy down. So the winter plan, which actually we'll be talking about this afternoon at the Joint Council of Governors and the board meeting this afternoon, so I won't go into the detail there, but there is lots of initiatives coming online, but I think we will need more because this, as I say, feels very unprecedented at the moment. But just to say, at the moment, we stepped down our critical incident a couple of weeks ago, after 4 weeks of being stepped up. We didn't achieve all of the objectives we wanted, but we did reduce the not meeting criteria to reside from 111 down to 67, which was really good work across the whole system, which made a great difference. We need to reduce that more though, and that is part of the winter plan. So that was the first thing that I really wanted to be talking about and to highlight. And as I say, we'll be talking about that more later. The second item I just wanted to flag was our significant increase in cancer referrals. So in the report, it talks about the increase of about 130% from June through to August. In September, that was up to 135%. We had predicted that we would achieve the cancer 2-week wait standard at 93% by July, but this increase in referral is just keeping us below that. We're around about 92% on that. With all of the services within that, and that includes breast care, we are putting on additional clinics to try and keep pace with that level of referrals, and we are doing that. We are treading water, but it is very, very difficult for all the teams because that is such a massive increase. And just on the breast care, just to flag that again across the ICS, all trusts are struggling with this, and they've been requesting mutual aid, which we have been unable to provide because actually we've got our own pressures with this as well. But as I say, we're holding water with that. And then the third issue I just wanted to flag was and to alert the board to, was one around the national guidance for RTT. So this guidance was reissued back at the start of the COVID pandemic, and it's been amended and updated at regular intervals. And it's really guidance about how we manage our COVID patients through this period. So the people who, for clinical reasons, probably oughtn't to come in yet, or for those who are fearful to come in. So the guidance has changed. We've been coding all of our patients on a waiting list, and colleagues will be aware that quite early on in the pandemic, we created locally the PER and the ARC list, which is essentially holding and wrapping around that group of patients who either can't or don't wish to come in, alongside our active waiting list. The latest guidance and clarification from NHS England, because as you might imagine, a lot of trusts did a lot of different things during the last 18 months. But the latest advice is that actually these patients should be on the active waiting list. So it's a status. So what we're doing is the right thing, but they need to go onto the active waiting list, which will change our profiles of 52 and 104 week waiters. So we're going through a repeat clinical validation of all of these patients at the moment, and there are around 800, case by case review, and the outcome of that will either be they are discharged because they never want to come in, or they go on to the active waiting list, and there will be a cohort that it's legitimate to keep them on an active monitoring list. That's a small number of those. So we're going through that at the moment. and then we'll conclude that over the next 2 weeks, and we'll report that back through to Finance Committee, but also to Quality Committee, which has the oversight of all our harms and safety issues on the waiting list. So that was all from me, Chair. Thank you.
Thank you. Okay, I'll just check with colleagues. Seem clear. The 104-week wait's a worry because that is a major focus at the moment. You're saying, Kate, that our numbers will show us an increase.
The trajectory requirements for 104-week wait is to have 0 by the end of the year, but that excludes the code of P5, which these patients are.
Okay, thank
you.
you.
If that makes sense.
Yeah, it does. Yeah, thank you. Okay. Chris, back to you.
Thank you, Chairman. I'll go to Dave for his updates, and I'll finish after that, Chair, with just a final single remark about finance.
Thank you. David?
Yeah, thanks, Chris. Thanks, Chair. I'm just mindful of time, so I'll rattle through mine fairly quickly if I can. And I think that the vacancy issues, the nuances of looking beneath the headline figures, I think is really key, as we saw with the maternity services. And I think that's what we're going to be focusing on. I talked to Adrian yesterday about focusing the next people committee much more risk focused on actions and mitigation. So we will be able to, I think, give a board a greater level of assurance around some of the key issues at future board meetings, and once we've updated the IPR. Medical recruitment, we're particularly focused on at the moment, the 31.7 whole-time equivalent vacancies at consultant level. That's a slight under-exaggeration because a number of other vacancies are covered by locum consultants. There's a piece of work driving a clear plan for each and every single one of those, including a modernisation. And again, we will feature that at the next people committee. In terms of sickness absence, it remains high at over 8%, and we are the 3rd worst in the Northwest, which means we will probably be in the worst 10 in the country, if not the worst 5 in the country. The work we've had with NHSIE on the evidence base hasn't delivered the improvements we were hoping for, so we're doing a focus in 4 particular areas at the moment. One's around a tenants improvement project, a health and wellbeing strategy, a focus on supporting those with long COVID, and then looking and understanding the vaccination status of others. And again, you will know that the national vaccination consultation on compulsory vaccination closed, and we await to see what the outcome from that is. Core skills framework compliance is driven by 2 particular courses, basic life support and departmental fire training, and face-to-face attendance at those has caused some issues at the moment. Rather than doing as we've always done, we're going to take a hive improvement approach to core skills framework and essential training, and to re-look at the whole of what we do, how we do it, how we record it, and refresher periods in order to get a sustainable position there. And the final point, which I think is really good news, 92% of colleagues have had their COVID vaccinations. 42% of that 92% have had their COVID booster, and 41% have had their flu vaccination, which is really positive. And I will come back to the point that we have 548 individuals that haven't been vaccinated, and we have a task and finish group that's just looking at what the options are around that group, ensuring that colleagues and our patients are kept safe. So they're the key points, a bit of a rattle through, and I'm sorry, but happy to answer any questions.
Looking round, Jackie, and then Adrian.
David, thanks for that. I was just going to offer as the DIPS, if you want any support on your task and finish group about the management of staff who've not been vaccinated, happy to get involved. I've done something similar in the past, and I think once you've got those stratified ways of working sorted, it helps the process. So happy to support that.
That will be really welcome, Jackie. Thank you. We do have infection prevention and health and safety on that group, but actually to have the DIPSI would be a real coup. So thank you.
Thank you. Adrian?
Thanks, David, for the particularly for the information around the retention of colleagues and just those reasons why people are exiting the trust. That was really helpful, and I know will be really useful in terms of strategic planning going forward. My question really was about the vaccination national guidance. I know that that information's come out for the care professions, and that's been a requirement, hasn't it? And I wondered what your view was, whether you suggested that it's going to be imminent, whether it's going to be a requirement or guidance. And if it's guidance, how will we deal with that? Will that come back to the board? Because I realise that potentially may be quite a, well, it may need to be very well considered in terms of our response on that.
Absolutely. Whilst the consultation has closed, I think the Secretary of State has made it very clear what his expectation is, and there was a statement from NHS employers yesterday around just looking at the implications and understanding and looking at what's happened in the care sector as a consequence of that happening. So the aim of the task and finish group is to prepare what the options are and what the risks are both, particularly if we are not mandated to vaccine. I think it's different then, but if we are mandated, then we just got to work that through. But of course we'll have to work through the pros and cons of what we do and how we do it and the timeline for doing it.
Okay, thank you.
Thank you. Liz?
Yeah, so my question, Dave, is around the information you supplied about leavers, and I noticed that 94 leavers had less than 12 months service, which to me seems quite a high number. I know it notes that 19 of those, it was the end of a fixed term contract, fair enough, but of the rest, has he done any detailed further work on that? You know, is it down to the fact that we got the wrong person, we were recruiting to the wrong role, wrong expectations? Because it's a lot of effort to go to recruit and bring people in, and then only to find they leave in less than a year.
There's a piece of analysis that's just being undertaken at the moment to understand that a little bit further. We have been in an exceptional year because of COVID. So we're trying to recognise that. It feels like it's a spike compared to normal, having such a level of turnover in that first year. But we're just going to do the analysis and understand it, and then we'll take some intelligent action on the back of what the analysis is telling us.
Thanks, Liz. David, there doesn't seem to be anything else. Ben, forgive me, I know that you put something in the chat space, but we can't access it from here. So I'll just give the opportunity. Do you want to say anything, or are you happy for it to remain in the chat?
No, I was just putting in there that it'll be interesting to see whether it's all NHS staff it gets mandated for or frontline only. Because one of my concerns on behalf of staff side is, you know, we've got a number of colleagues who work from home, and if they're choosing not to have the vaccine, are we really willing to lose those staff who aren't coming in on site just because they haven't had a vaccine?
We'll wait for the guidance, and then, good point though, Ben. We'll wait for the guidance and then come back to that. David, you got your hand up?
Yeah, it's just to respond. Ben and I had a really good catch up about this yesterday, and the need to take a compassionate view, recognising all of the issues, because it's not quite as simple as anyone might make out, and that we need to think through any intended or unintended consequences of any action that we take.
Thank you. The same equally applies to our community staff. Although they're NHS financed and have a contract with us, the NMC guidelines around nurses working in social care and access to homes, etc., states that they should be fully vaccinated because that's a social care requirement. They won't be allowed in otherwise. So there's some interesting community repercussions. But I think, David, there's no further comments to you.
Chair, just to conclude on the finance point, as I said, things that we'll cover elsewhere on the agenda, but it is worth noting that we were set a H1 plan target. We achieved that. Financial balance is the third time in a row the trust has achieved its targets. Financially, we recognise that there would be some limitations about how that would be delivered, and in fact there have been. And we are clear about the risks going into half 2, but notwithstanding its financial balance was the ask, and trust was delivered.
Yeah, I know we've got HT planning as an agenda item later, so thank you for that. We know that, Chris. I don't think there's any comments on that, Sarah? Sorry.
Thank you. Just a question related to that. So I noted that part of that balance came from an injection of those sample from the ICS. Is that right in terms of the elective recovery work? And so I think my question is not a challenge, but the question was, does that potentially impact on, for example, our exit criteria or how we may be viewed in the future if that has been achieved through external partners contributing?
I don't think that in itself is a material issue for how our financial improvement will be judged. Noting that the reason that that injection was required was that our financial position was impacted materially because of the operation of the elective recovery fund as a system allocation, and there were issues about how the funding for core levels of activity had been distributed. So I think it's a very specific half-1 issue, and I think it was a reasonable solution to a problem, as is required of systems to work together to mitigate risk.
Thank you.
Thank you. Thank you, Chris. Have you completed your performance report?
Yes, thank you, Chair.
Thank you. Colleagues, we'll move on then. Item 142, the 3A reports from the Assurance Committee, Audit, Finance and Quality in that order. So if you could just bring us the main 3A items, please. Liz, we start with you with Audit.
So I won't excuse me, refer to the minutes of the meeting from July, because I think we reported those up to board before that. But our recent October report, we received the auditor's report, and in their assessment, Grant Thornton made key recommendations in relation to financial sustainability and clinical governance. And as the Trust had demonstrated the progress made against these areas, Grant Thornton had elected not to use their statutory powers. However, that there is a risk there that the board needs to be aware of, that we do need to show progress, and this will be revisited in June. So if there isn't sufficient progress being shown and trajectories improving, then obviously they may need to reconsider their decision next year. MIA, our internal auditors, emphasise the importance in their reports about their recommendations being actioned and embedded, and that there's a number of outstanding recommendations going back a year or two that haven't been implemented yet, and the committee has undertaken that they will follow up those with executive leads. They also brought to our attention that a number of audits undertaken showed significant assurance for procedures and policies being in place. However, limited assurance was shown, found from being those policies and procedures being implemented on the ground. And this is obviously something that came to light from the CQC report. So again, this will be followed up.
Thank you. Okay. I recognise these are words, comments from the assurance committees, but I'll just look around. Colleagues happy to receive that. Steve?
Thank you, Chair. I'll just take some minutes to take you through the perspective from the Finance Committee. And as our meeting is always so close to the board, it's difficult to get the papers through to you. I have circulated them through to the NEDs. Under the alert heading, I suppose there's 2 items. The first is the significant uncertainty around the allocation of money in half 2. It seems to be changing every time I talk to Chris, and probably 3 times a week for him as well. So that's a material risk to the achievement, because we don't actually know what we've got to achieve. The second alert, and I think Kate's kind of covered it, but we really highlighted it this month, was the stress in the emergency department and the trolley weights and the triage, an area where in the past, we've been performing quite well. So that front door diagnostic really is showing stress this time. Under assurance, I think the most important point we're seeing in the committee is when we try to get commentary through from care group leads, and I mean the care group leads, not the accountants who are working in the care groups. We're getting very little assurance that the CIP targets and improvements can be delivered. And that's largely down to staffing concerns. I mean, we may be wrong, but I just want the board to be very clear at this point in the year that as an assurance committee, we can't put our hands on any assurance there. And that's, to be honest, a familiar position. We've been in that position in previous years at this time of the year. One of the things we're doing as a result of that is to try and do more work as NEDs to get alongside the care group leads to try and get that assurance. We haven't really spent a lot of time doing that. So that's a bit of a personal mission of ours to do that through our contact with the care groups. There is, on a more positive note, I think we do take some reassurance from the recovery support programme, the way that's been structured, from the way that CIPs are being linked to clinical strategy work, and how the additional resources are being used to look at the outcomes from previous investments. So all that is good preparatory work that we've not had before, but it's still, the message still is everybody agrees with the opportunity, but it's grasping the delivery that is the challenge. And then a few points on the advice heading. Our committee will meet additionally on the 8th of November to review the H2 submission on behalf of the board. Another item coming back to the elective recovery fund, and Chris teed this up really. I think one of the many changes in the definition of this arrangement has been a measure that's used to measure activity. So they're using something called clock stops now, which others in the room will know much more about what that means than me, but there is a potential quality issue there. So there was a suggestion that quality committee should just make sure or satisfy itself that there isn't any change in behaviour there around that measurement that might cause some difficulties. And finally, as a committee, we are intending now only to spend time scrutinising the financial results on a quarterly basis. We'll still receive the monthly reports and look at them. We won't sit down and debate them. We're going to free up that time to examine in more detail deep dive topics. I think a route that the People Committee and other committees have used. So our first candidate, we're going to try and look more in detail at the whole business of capacity management in November. And then in December, possibly take more of a deeper look at the whole business of patient records, common patient records, and from an I3 perspective, how we are organising ourselves to achieve the deadline there. I think there's an item on the BAF or the risk register that has a delivery date of 2025. We'd like to get more into that and see what progress we're making towards that date. Thank you, Chair.
Thank you, Steve. Comments? Just
thanks. So two actions I think that follow from those two updates. One is the issues that the Audit Committee have raised around sustainability and delivery of audit work. And Chris's audit would be a good thing to bring to TMG, so we've got sight of where the delays or the issues are in delivering against those, so we can take that through that platform. Similarly, on the issue around assurance on H2, particularly on the efficiency delivery, I think there's plenty of work going on now under the RSP and the SPIP agenda that's going to give us a greater clarity of what the longer term delivery is. But we've got a 26-week target and we need to achieve that. So again, I think we need to highlight to TMG with the care group leads what we might need to do and galvanise in a different way outside of an assurance committee conversation. We'll pick those two up as action through TMG.
okay, thank you. Chris?
Yeah, and then just linked to that, I mean, we're already, I've seen a first draft of revised assurance and governance reporting through to the TMG based on those specific issues. So that will come on. I would say just the board should note that Steve reported on the funding uncertainty. And the context of that is that it creates a situation where, because we're already in October, we may be committing resource that we're going to struggle to cover off one way or another. And that does, right, in particular to the ERF, but also our elective recovery fund, but also other elements of the regime. Now, I have just, so the board's aware, and I've briefed the committee on this, made formal representation seeking clarification and guidance from the ICS about governance, oversight and decision making. And I'll be pursuing those items and I'll brief back accordingly based on what that means. So I know that sounds a bit vague, but they're very specific questions.
Thanks very much on the recommendations in item 143 as well. So, and just Paul and Nicola are taking the minutes just to clarify. The Finance Committee is proposing on the next item the delegated authority to look at the H2 funding in November. So we haven't yet approved that. We'll discuss that in the next item, but it's coming from Finance. Thank you for those comments. Quality Committee, Jill.
Thank you. Just a point about the papers. I would find it very helpful if the 3A papers from each of the quality were actually a substantive item on the agenda and the reports were there, rather than having to dig them out of the reference pack, because the purpose of doing them is so that we can alert the board. So just the 3A reports, if they could be part of the papers and not in the reference pack next time, that would be helpful. Thank you. What I want to say on the quality, we had a long discussion about the arthritis audit, and we've asked that to come back to the committee because we are not able to consistently comply with the standards. Having said that, we're better than other local trusts and they're referring people to us for an arthritis service. However, we are not meeting the standards and we need to keep monitoring that. It has a feel to it, just like the stroke service did, where we've known for a while we haven't got the resources to meet that. The reassuring thing is that actually a number of items from quality were on the agenda today, so thank you for that. Things like we talked about the staffing issues in women's and children's and the mortality data. Finally, I want to say we also looked in detail at the root cause analysis report on the section 31 stroke pathway and what we had actually learned from that. And that was very critical, I think, to how we would go forward as a quality committee and what kind of assurance we'll be looking for in the future. Thank you.
Thank you. Thanks, Jill. Okay, looking round, comments. Thank you. Thank you for the three chairs of those committees. We'll move on then. I think we've actually covered a little bit of item 143, Chris, in the last item and the integrated performance, but can you bring us up to the main points on H2 planning, please?
Thank you, Chair. The report was discussed, as you say, in detail at the recent Finance and Performance Committee, which met on Monday this week. And you've heard Steve's brief as chair of that committee. It is, I would like to remind the board, I know it's understood, but this is the second planning round of the year and is a process which detail and guidance was only issued at the end of September, and therefore grateful for the support of the Finance and Performance Committee to agree to an extraordinary meeting to consider plans further in line with the timetables that have been issued. It is a planning process that's operated through our integrated care system, so we have to coordinate with them, and the integrated care system actually makes submissions that precede organisational returns, and then organisations are required to reconcile into that, so it's quite a complex piece. The summary sheet specifically identifies financial risks associated with the elective recovery fund for the second half of the year and the risk that the cost of delivery of activity is likely to exceed additional funding generated through the elective recovery fund. But I have to stress that the process is not concluded on that yet. So we will ensure that colleagues are kept properly up to speed with that. Also, the fact that the distribution of the system funding allocations is not finalised until the planning process is finalised. And just to bring that into context for the board, that's of the order of £48 million for this trust in the second part of the year that is distributed through those mechanisms. We have, as I said, made formal representation where there are some issues we're seeking clarification of from the ICS, and we will continue to work to conclude that with our colleagues. In terms of the board, I would just finally bring the board's attention to our initial assessment of the financial challenge facing the trust in the second half of the financial year. It is set out in the reference pack, noting it's not final position yet, until system resource allocations and plans are agreed. And also contained within the slides are the key identified planning risks for which mitigations and planning judgments will be set out as required as part of our half-2 planning submissions. Thank you, Chair.
I think the report speaks for itself, still a requirement for clarity in several areas really. We're asked to look at this. We've got the guidance for H2 such as it is. We'll wait for further clarification. I think you'll accept that, colleagues. Acknowledge the continual development of the plans as further guidance is received. I think that's the reality. And the final one, agree to delegate authority to the Finance Committee to approve the H2 plans on behalf of the board. Yep. Great, thank you. Okay, Chris, thank you. I know this is a rolling programme, must be extremely difficult. Okay. Item 144 then, the Q2 review of the 21-22 key areas of focus. I'll ask Aaron to start off. We're then asked in the second half to review the BAF. So Paul will come in at that point, but over to you, Aaron.
Thanks, Chair. Just a few minutes. So this is part of our governance arrangements as a board, where periodically each quarter we come out of the IPR and think about where we are against the key objectives we set for the year. Any key risks or issues that are presented and what impact that might have on strategic delivery or our board assurance framework. So the 3 key priorities we've agreed as a board around the colleague psychological health and well-being as a priority, the quality and safety of services and maintaining the good, safe delivery of services in this period is a priority, and also around improving our financial performance and the transformation of our services through things like the clinical operating model and the HIME infrastructure we've established. They were set out at the start of the financial year. We've taken a review of the current quarter's delivery through care groups, through our trust management group and the assurance committees. And you have a cover sheet and a set of slides circulated which highlight against each of those areas what we believe has gone well over the last quarter, what we think has not gone so good and what we want to focus on, and what we think the Q3 priorities need to look like as a result. So without going those through those section by section, generally what's gone well through this quarter, through the summer period, you will have heard through board reports outside of the IPR, including today. So things like our stroke improvement work has progressed really well over Q2. The work that we've done that Chris has just highlighted on achieving our H1 financial target, not in the way that we would have liked, but delivering it nonetheless under the circumstances that we've had in the first half of the year is to be recognised. We have made improvements on our elective recovery work, particularly around cancer and RTT. We've got new structures established under the Good Governance Institute now working more effectively. And we've also mobilised, set up and established the recovery support programme over this period to the extent in which we were proposing today approvals for board and into the System Improvement Board tomorrow. We've also finished and finalised now the Good Governance Institute assurance structural changes, and we'll report into board next month as to how we are assured that they're going to be working effectively and sustainably in the future. Issues that have been highlighted through this quarter, particularly from the lens of the CQC regulatory work. So we've seen highlighted concerns around 3 of our core services in urgent care, maternity and stroke. We've also seen issues highlighted in some of our medical services at RLI, and they've continued to highlight the immaturity, if you will, of the improvement work under that governance assurance and risk management development piece that we put forward. We've obviously had the notification of the SOF 4 rating over this quarter and the establishment of the recovery support programme, and pleased obviously with Caroline, Lorna joining us in their roles. Thank you, Caroline. And with Jackie and Damien continuing to support Jackie more formally in the recent months. Thank you. You will also have heard around key risks in things like C. diff rates, our urgent care performance, and the capacity generally of our clinical and operational teams through increased workforce absence. So there's some areas of issues or concerns that we've highlighted above through the last quarter. What that means then for us going forward is Q3. is a real focus on a number of areas to highlight to board. First and foremost, it's about the resilience of our workforce. Staffing is the highest risk now in our organisation. And when we talk about the board assurance framework, I just want to have a minute to share that I've asked for a greater review of our mitigating plans and what we're doing around health and wellbeing, recruitment and retention, that Dave's going to lead into trust management group. And I would suggest we bring something specific on workforce into the next board, Chair. Our urgent care fragility and the urgent care pathways that Kate highlighted in the IPR. The board is already cited on our mitigating plans for winter, which we've agreed, which is the urgent care improvement programme. That still needs close oversight and partner support, not just in the programmes of work we've mobilised, but ensuring they're delivering as they should and that we're managing risk collectively as a system. And again, the board will retain significant oversight of that through the monthly performance and assurance reports that come through the relevant committee. And the third area is the issue we've just talked about around the uncertainty around the financial position in H2 and increasingly a focus on 22-23 because we're right in that frame now as the longer term financial trajectories. So the other areas then just to highlight that the board will have focus on or will need assurance around. We are in the transitional period of recruiting to a number of executive team posts over this quarter. I'll be working with colleagues on an executive team development programme, small d, just to get teams together and aligned and making sure we're all connected onto the remainder of this year and planning for next year. And we've also got the work that we need to commit to on the development of our integrated care system with the appointments being made there, the place-based partnership development and our own ambitions around the provider collaborative board. So a mixed picture in Q2. I think our team should be congratulated on the work that they're doing on managing unprecedented pressures. I know that gets mentioned a lot, but it's a fact, that's what they are. And the regulatory environment responding to that really positively, but highlighting that we've got some specific risks and areas of focus for this next quarter as a board. And you'll see some of that play out in the board agendas and the way that we take work through the assurance committees and TMG over this period. So that's as much as I was going to say on the quarter review, Chair, as well as the slides that have been circulated. And at that point, I would hand over to Paul, unless you want to pause for questions there on the board assurance.
Let's just pause here before I bring Paul in. Any questions on that? So basically, to summarise what the Chief Exec has said, there are three major risk areas for the Trust: workforce, finance, and obviously the quality of care and safety. And I'm not prioritising those. I think they're all interconnected. That's basically the three major areas for our Q3 focus. Obviously, within all that is the exit criteria and the work of the improvement team. I think you've summarised it well there, Aaron, but just checking anything before we go on to Paul.
I suppose the question would be how those, just a little on how those priorities will be cascaded through to care group leadership and how that process works. Be very helpful, either outside the meeting or quickly here.
Yeah, so we take this through the trust management group, care groups and executive together. We realign the risks and priorities and then they cascade through the care groups via the trust management group. Interestingly, focus on our workforce, focus on quality and safety, urgent care and finance. They are the three key priorities that were established through the course of the year. What we need to do now is make sure that our limited resources are pointing more purposefully about the specific risks we're seeing. So I've just asked for the TMG to have a slightly different kind of oversight and discussion about where we prioritise over this period. It is traditionally the most difficult period of the year for us anyway.
Thank you.
For NEDs, remember we're pairing off with care groups and we're doing clinical visits and they seem very good issues and questions to raise with our managers and staff that we need in care groups.
Could I just ask a further question just on your response, Aaron, and that was about from TMG, as well as the effective planning and opportunities, particularly to address issues around workforce, which are immediate. I'm really sure that it is your top priority. Will TMG actually receive ongoing real-time data about the impact on staff of those services? So our services being delivered, which actually meet the needs of staff? Is it actually having an impact on, for example, reductions in sickness or staff improvements in staff wellbeing? Because that's the step beyond just the effective planning, really. It's actually seeing tangible, beneficial outcomes for staff, and that's what I would like to be assured of, that that's going to be actively reviewed by TMG.
Yeah, it's more of an assurance piece, that, Adrian, so it will come through the Workforce Assurance Committee for evidence of how that's being delivered and the assurance. But for the TMG that meets weekly, it's more the executive operational kind of drumbeat. So making sure that we're prioritising. We have a regular hotspots agenda so we can spot issues early and take appropriate action. And then we start to bring back through, we look at the IPR monthly as well as an executive function around any key changes. But specific deep dive assurance, I would suggest that the Workforce Committee starts to ask if there's anything else that you want to see through the executive functions we bring it through the Assurance Committee.
Great, we'll do that. Thank you.
Thanks. Okay, Paul?
Thanks, Mike. Within the documents which have been circulated to board, there's a reminder of what was agreed by the board during Q1, which was 8 risks to achieving the strategic objectives and the scores that were related to that. At the end of Q1, we did highlight a number of potential material issues, including the CQC report, H1 outcomes, uncertainties around H2, and so on. So what we've done is, really following on from the presentation that Aaron gave, we've looked at that kind of mixed picture. We looked at the publication of the CQC report, placement into segment 4 of the Single Oversight Framework, admission to the Recovery Support Programme, ongoing pressures, maintaining safe staffing levels and workforce matters, and we revised the Board Assurance Framework in that regard, and we've enclosed the table within your paper summarising the changes. So quickly take you through those. There are no new risks. However, revised risk descriptors have been prepared to reflect the changes in Q2 and the changes to kind of the risk profile and exposure, and to make the risks more precise. The most substantial change, though, beyond that, is that the BAF has actually been reviewed to align to a number of the programmes of work within the recovery support programme and preventative controls, i.e. the actions we're actually taking to reduce the likelihood of the risks occurring, to make sure you achieve your objectives, and those are what you're going to be seeking assurances on and delivery on within the next 2 quarters. So there are some changes embedded within there. I think it is just worth, as well as Aaron said, as we did at the last one, just to sort of say that there will be ongoing review of the Board Assurance Framework. Aaron's already highlighted the potential risk from kind of workforce issues. We also mentioned H2. We've also mentioned ongoing operational pressures, and I think the other one to be mindful of is a number of external reviews as well, which we'll be expecting in the next quarter. So there are no changes to the scores, but in the summary table, you can see kind of the rationale for the proposals, and the new descriptors are there. With that, Mike, I'll take any questions, but ask the board to receive the Board Assurance Framework, noting the comment Aaron made around additional focus on the workforce element within the Board Assurance Framework as the first priority in the next cycle. Thank you.
Yeah, so it is noting that when we set the Board Assurance Framework at the start of the year, we have a number of high risks. So they would have to materially deteriorate, I think, for them to go higher still. There were key areas of focus for us as a board. The one area that I will highlight because of its impact, that I think once we've had the TMG discussion later this month around workforce, is a potential for that workforce overall corporate risk to be reviewed. And if it does change as a result of that executive functional review, we'll bring it back as a separate item through the board next month under that workforce item that I've asked Dave to lead on.
Okay, thank you. And it may be a very naive question here, but it's to you, Paul. What are we doing with the BAF?
So the BAF becomes our reference tool, Mike. So as Aaron alluded to, it will drive the business of both the board and the assurance committees. So what we will do with the BAF, and we'll begin to sort of say, are we seeing the areas of focus that are described in the BAF in terms of kind of particularly the areas of assurance? Where are we getting our assurances from? Have we seen those assurances? Have we seen the management reports? Have we seen the external reviews? Are we seeing, we've referenced in there, for example, the external auditors review on that, and are we taking that into account, and are we following it through in the way that we've described? And then we'll map that And then when we get to the end of the quarter where we haven't had those assurances, we'll flag those and raise those with the assurance committees and the executive team and through TMG.
Can I request then that the subcommittees of the board that you refer to the BAF when you have your meetings somewhere in the minutes, so that we've got a record that the subcommittees are also tying in their risk work with the BAF, and then that can come here in the 3 monthly review as well. Steve?
Yeah, I'd just like to thank Paul for the work he's done. I think it's easier for us to do that now, the way it's been structured.
Yeah, good work. Yeah. Okay, all right. Thank you for that. We're asked to consider the progress made in Q2. Chief Exec has outlined that. You've talked about the specific risks and the actions required for Q3. Do we approve the revisions to the BAF as outlined by Paul? Yeah. And approve the assurance framework for the infection prevention control risks? Yeah, thank you. And then we'll just add another note there that the subcommittee's result will also incorporate the BAFs into their report back to the board. Great, thank you. We'll move on then to item 145. Debbie, welcome. Debbie Fisher. I'll ask David to lead us on this paper and introduce you to the board. David?
Yeah, thanks, Chair, and again, welcome to Debbie and Tess from Clever Together. You recall at the last board meeting, you approved the use of a cultural engagement platform in order to speed up cultural transformation. We said that we would invite Debbie along just to give an overview of the system, how it will work, and a bit of an introduction to the sorts of things that we're going to be posing. Debbie does know that she's only got 15 minutes, so we will canter through this as quickly as possible. But the speed at which we do this isn't reflective of the importance of this particular exercise. It's absolutely essential to our recovery support programme, but the pace in which we're looking to mobilise this can't be missed, and I think that will be really clear as Debbie takes us through our presentation. So, Debbie, over to you.
Thanks, David. Hi, everybody. I'm Debbie Fisher, one of the directors with Clever Together. I'm joined by my colleague Tess today. Thanks for giving us a little slot on your board agenda to talk about culture and the importance of getting staff on board with the kinds of culture transformation that you want to make. For those of you who don't know anything about us, Clever Together are a small organisation, an agency really, who work with all sorts of different organisations, but also lots of NHS trusts, to really make sure that we are hearing from the voice of staff and engaging them in the culture change journey. And the way that we do that is by providing a digital platform and lots of support around the outside of that to create an online psychologically safe space for staff to share their views and opinions and experiences about all the important topics that are going to help us to understand which levers are the right ones to pull in terms of changing the culture, and really sort of building on the things that are good, but also tackling some of the things that maybe aren't so great across the whole organisation. I'm just going to share with you really quickly some slides, and then Tess and I would really value a bit of discussion and some viewpoints from you as a board about sort of where to target this conversation. So bear with me while I just share my screen, and then I will, I'm hoping that you can see this. Someone just give me a nod. David, I can see you in the corner of my screen. Yeah,
we can see it, Tess. Can you make it large though? There we are.
There you go. How about that? Okay, so I have to sacrifice your beautiful faces in order to share my screen. So David, if anybody asks a question or puts a hand up, if you wouldn't mind just flagging it to me, that would be great. So basically, what are big conversations? They are a space for everybody to contribute and have their say. It's based on the principles of creating a psychologically safe, anonymised digital platform that's hosted independently from your organisation. So Clever Together hold that platform outside of your organisation and guarantee the anonymity of any individuals and their contributions. So it's for all colleagues of every level from anywhere across your whole organisation. It's for for domestics, it's for porters, it's for executives, it's for all of your leaders, your ward clerks, whoever you've got in your organisation to contribute and share their views and opinions. We host a big conversation, generally speaking, for 3 to 4 weeks max. And it's available 24/7, which suits all of our shift working patterns, and allows people to join in when they've got the headspace of being at home, perhaps, or over the weekend, if that's when people have their best thinking space. And it's completely accessible from any internet-enabled device. The conversation topic is something that we're going to come on to shortly. But basically, we agree what's the most useful conversation that we want to have with all of our staff to really start to understand the rich picture of what's going on for them and where we can sort of best focus our efforts in terms of culture change. So Tess and I and our team of analysts then go through and they thematically analyse. They read every single contribution that people make, and we thematically analyse and pull them all together into this kind of series of the big levers, the big culture change opportunities that are in front of you, voiced by your people that are going to make the kinds of changes that they want to see. We are able to analyse that information by different groups, so we can look at whether the opinions are the same across the board or whether there are particular themes emerging in particular areas. And we're able to, while the conversation is live, target any additional communications towards groups that we don't hear from as much as we would like to. So we're able to identify who's joining in and where to target our efforts. And really what we're seeking with this process of holding a big conversation is that we have a co-created future together. People feel like they have invested their time and effort. They are much more likely to therefore go forwards, make those changes for themselves, and behaviour change happens in a really inclusive kind of way. So Clever Together's methodology.
I think we may have lost you a little bit there, Debbie. Colleagues, can other colleagues hear? No. I think we may have lost the connection there.
I can still hear you. Let me stop sharing my screen.
Yeah, we can hear you now.
You can hear me, but I can't share at the same time.
Would you like me to share, Debbie? Is that helpful?
Yeah, try doing that, Tess. Thank you. I'll talk. You can share. So the first stage is mandate. It's all about why are we doing this? Why do we believe that staff engagement is important to our organisation? And what is the promise that you as leaders want to make to your people? So what do they get in terms of a promise from you if they share their views and opinions? The second stage is about how we generate interest. So the idea is that we make sure that everybody across the whole organisation knows that this is an opportunity for them to join in with. We aren't going to hear from absolutely everybody, as you'll know from your kind of staff survey work. We don't always hear from everybody, but the idea is that everybody knows that it is something that they can contribute to and they can influence the changes that are going to happen as a result. We then go through in this step 3, making sure that we've really understood what the insights are. How do we hear those really core messages from staff about what's going to make the big differences for them? And then the final stage is about how do we turn all of that stuff into action, agreeing what kind of culture transformation we want to have and what kind of culture transformation is going to take in terms of action. So I'm hoping that that's relatively clear. What we'd like to just do with you is kind of get an understanding from you about why you as a board feel that staff engagement is really important in changing culture, because that helps us to create the narrative around the platform itself and to explain with the comms how this is going to work and why people should get engaged. And then we'd like to have a conversation with you about potential campaign name and the big conversation questions if we get time to do that, appreciating we've only got a short window of time. One thing I'd just like to do really quickly is just to I'm going to try and share my screen again, just to show you some of the platforms that we've actually got live at the moment, because I always think it comes to life when you can see it. And some of you may well have worked with these platforms in the past as well, or some of them you might even recognise from other things that we run across the system, across the nation, primarily with the NHS. I'm hoping you can see my screen at the moment, but I'm just showing you one here that's for the New Hospitals programme, which some of you might be aware of. This is a sort of typical platform. We come up with a branding for it and some design work. We normally have a little video to explain it to people if they're not such a fan of the reading the written word. And then people can go and join in with the conversation. This is one that we've just been doing with SAF, Shrewsbury and Telford hospitals, who have really decided that putting staff at the heart of their cultural transformation is really important. Trying to get them sort of back on the bus, if you'll excuse that rather overused phrase, but it's about trying to make sure that we've really got people bought in. So this is one of the pages that we have for them, which allows us just to find out who's joining the conversation and ask a few sort of snippets of different conversations to give us a sense of who's participating and why. I think it's not going to let me join in. Excuse me while I log in as admin. So that's the front page. Nice simple login. Not sure if it's going to let me click through. So these are what we call gateway questions. They're the questions that just allow us to get a sense of what's going on for people. We're expecting that we are going to, I don't want to be a doctor. There you go. So this is the conversation that they've got live at the moment. It's about their medical engagement strategy and about how they can join in with that. We're just about to launch that hopefully tomorrow with their medical teams to understand a little bit more about the kinds of things that they need to do for their medical engagement strategy. So this is the kind of thing that we are wanting to get your views on, really, is what are these big conversation topics that you feel would be really important for you right now? And everybody can add their new ideas and engage in that way. So 2 questions for you. So first of all, why do you feel that staff engagement is the important way to change cultures? And the second is around the campaign and the questions. Any thoughts?
Debbie, I assume they're rhetorical because I don't think we've got the time to have a go around board members. Or are you just asking for odd comments?
Odd comments would be really helpful, yeah.
Stephen?
A couple of observations, Debbie. I suppose one, the rather boring one, is whatever you do as a result after this, then there's a sort of legitimacy because you've consulted with everyone. But I think the more significant thing is you're accessing the maximum knowledge base of the organisation and to access the creativity of the people in solving the problems. Just 2 observations.
Brilliant. That's really lovely language as well. Thank you.
Just bring Chris in.
Connected to Steve's, expand our frame of reference and through promotion of diversity in our approach, we'll get better outcomes, and that's known to be the case.
Sarah and Aaron.
A question about inclusivity, actually. So if everything's done online, how are we going to actually ensure that staff who perhaps don't have access to that at home can do it through terminals or something on site? And then I think something about language and the kind of language that's used to make sure it's engaging for all staff and not just certain sections of staff who may be more familiar with the language that's being used.
Brilliant, yeah.
Thank you. Aaron?
So I guess the question about, how important is it to have colleague engagement as the part of the cultural change? Well, it's fundamental, isn't it? So I think just recognising that we've had a number of attempts around culture improvement as an organisation. And I've said as a board before, we're quite deficit based. We use pop-ups, we've got an issue here, so let's wrap something around it, or we've got a programme here, so let's wrap something around it. So I think this will be the first time that we've engaged with potentially all our 8,000 people to really test what it is actually that we want to do as a positive cultural, like a pull agenda rather than pushing away from something. And the other point I would make is I'm really looking for the questions that we pose to test some hypotheses. So we have an ambition as a board to put patients first, to be quality and safety driven, to be clinically led. How close are we to that now? Or would our colleagues tell us that the things that they would see as important? So I think there's, in the framing of the questions, there's some hypothesis testing that we need to get back, so we don't kind of fall into the trap of the 15 of us around the table knowing that we've got the answer, we're just going to push something out. So they're 2 or 3 things for me that we need to consider in what we call it and how we frame the questions, which I've given some feedback already to Susie particularly.
Brilliant, that's really helpful, thank you.
Okay, David?
Yeah, I'm really mindful because I think we've probably exhausted the 15 minutes we've got. So I think it's been really helpful, I think, in giving a flavour and a bit of an overview of where we're going. The questions around brand name not being initiative-itis, I think, is a really clear one, and we can put that into the programme group that's looking to set this up, that's meeting again tomorrow, and also shaping the questions so that there's not too many questions, but they're sufficiently open to allow us to test that hypothesis without revealing what we think the answer might be, because I think that's a mistake as well. So hopefully board colleagues got enough from that today to understand it, and they'll see it launch through November with the support from Debbie and Tess. So thanks very much.
Yeah, thank you. Quick one from me, David, just on process. You mentioned, Debbie, the Cultural Transformation Programme Board. Is that an executive? Yeah, that's all I wanted to know. Thank you. Thanks, David. Thanks, Debbie. Thanks, Tess.
Ben, comment in the chat, Chair.
Ben, sorry again. Caroline, were you waving goodbye, or was that hand up to waving goodbye? Okay, Ben.
No, I'm good, thank you.
Okay, thank you. Okay, colleagues. Debbie, Tess, David, I'll close that item down then. Thank you. We'll see you again, no doubt.
Thank you very much, all.
And David, stay online because 146, becoming anti-racist, your paper.
Yeah, hopefully this will be really, really quick. This is the follow-up to last month's board paper, which actually got some positive media coverage about the board getting serious about tackling racism. This paper sets out the focus for each of the 5 work streams with outcomes, impact, actions and timelines that will enable us to create a positive difference. So please can you support and agree the action plans that are in it.
Thank you. I think virtually all NEDs are involved in this in one way or another, so we've seen it. A couple of comments from me, David, and I apologise for on the Appendix A, some of the date lines refer to 2022, but it actually says 2021. So they probably just need, it's just the Appendix A. And then in Appendix C, the second point down, it says to be agreed with the system lead. So could you push the system leads to put a date in there, please? And also on Appendix D, under the date line, the staff survey to be completed by the 31st of March 23. And then the second one on the highest priority, it says the cultural dashboard to be confirmed. Again, can we have dates in there, please? Because I think the big driver for this is pace. We need date lines and we need change and observable change by set deadlines. So I think we push really hard for date lines there.
Agreed, and we will. The pace at which we're doing this, and the two, particularly with the cultural dashboard, because it links across the piece with the RSP. We just got to line our ducks up in a row first of all, Mike. But we'll have the dates in there as soon as possible.
Yeah, please. If we do within, at least by the end of this month, that gives you Friday, I think. Sorry, I'm really pushing the anti-racist work, so we need some action by Christmas. That's what we've set our deadline by. Okay, the recommendations, there are several. Oh, sorry, my apologies. You're sitting there quietly with your hand up.
No, Mike, it's not related to this item, but just to draw your attention to the fact that Heather's joined us, and I just wonder if we, once David's got his approvals and recommendations for this item, we can bring the medical director report forward so that Heather can attend her and present her annual report. I know she's got another commitment immediately after this meeting. Thank you.
Yeah, I'm happy with that. Yeah, Kathy, you okay with that? Okay. All right, then the recommendations are task and finish groups. Focus on the support on Appendix A to C. And then there are 4 recommendations, but they can be summed up as we're asked to note the action plans and drive forward the actions regarding the respective tasks and finished groups and make sure we achieve the agreed outcomes. Yeah, brilliant. Thanks, colleagues. We'll keep pushing on this one. Okay, then, Aaron, you just missed it. There's a request to bring in Heather now for Heather to give a report in before we go back to the partnership and the medical report. Heather, over to you, please.
Hi, is Kathy going to introduce it or just me? I don't mind.
Heather, I'll just let you do your bit because I know you're really pressured for time. So yeah, go for it.
Can them bring up the slides, please? The that I sent through. Paul's got them, or Nicola. Anyway, it's about what I want to do. We've put the annual report in, which I'm sure everyone's looked at, and that's great. And there's apologies from Wesley, who's unable to be here today, but we wanted to clarify what the Freedom to Speak Up Index meant, because there seems to be some confusion among some people within not just our trust, but lots of places. It refers to the whole culture of speaking up within the trust, not just the concerns that come through freedom to speak up. And they take this metric from the staff survey from 4 questions that I'll show you in the next slide in a minute. But you can see the higher the percentage is, the better able colleagues feel able to speak up, better supported and more confident that concerns will be replied to. So in 2019, we were 79%, which was above the national average. It still means 21% of people didn't feel able to raise actual clinical incidents it's based on. Then 2020, with the survey from 2019, it plummeted. So we were well below the national average. And it's now come up this year from last year's survey. So it is improving, but we are still well below the national average. So if you go on to the next slide, please. And these are the questions that they take the percentages from, and it's the percentage of staff who agree or strongly agree with these 4 questions. So 16A, we're below the average, though actually 60% for people thinking they're treated fairly isn't good anyway, it's a national average. And then 17B, we're also below the average, but this is quite skewed towards clinical incident reporting. They don't mention freedom to speak up. They don't talk about taking concerns in that direction. This is day-to-day incidents and concerns and how they're managed across the trust. So this year, in last year's survey as well, they had a new question, 18F, which asked workers if they felt safe to speak up about anything that concerns them within the organisation. And we are still well below the average, which isn't good either. We're 61.7%, but it is a good general question, and it's not quite so skewed towards clinical colleagues. But I've spoken to the National Guardian's Office, and so have lots of other guardians in the network, that we do think the name Freedom to Speak Up Index implies it is to do with concerns that come through our Freedom to Speak Up process, and it really isn't. It's a general cultural index, and they don't take in that 5th question on the metric. In the survey that we've just done, those 4 questions are phrased differently, so they're not being taken forward, and they're hoping to do an index relating to question 18F. That's the National Guardian's Office with NHS England, NHS information. So, so there should be another index next year, but it might not be called the Freedom to Speak Up Index, because there's a tendency for some trusts to think it doesn't relate to everything that comes through the trust, but it does. And then finally, if you go on to the last slide, this is some improvement ideas that we've had on how we can improve our index if they do one next year, and certainly improve the culture of speaking up. So we're increasing our ring fence time. That's for me and Wesley. So at the moment it's 0.8, it's going up to 1.2, because we have so many concerns. It's just not possible to have the time to join in with all the inclusive work and improvement work that's going on. And then the National Guardian's Office, who oversees our data, etc., they're promoting an e-learning package, which it is e-learning, but there are 3 modules which we want to promote through the trust. But due to COVID, they haven't managed to get the 3rd module done in time, which is a shame because it's Speak Up Month. So when the 3rd module is done, which is for senior managers, we would really appreciate the board promoting the e-learning package by doing it first, all 3 modules, and then we can use that to promote FTSE through the trust and speaking up. So that, I think that just about sums up what I was going to say about the Freedom to Speak Up Index. Obviously, if anyone's got any questions.
Thank you, Heather. That's very concise, very clear. I'm looking around colleagues, certainly here, everybody seems to be agreeing that the board will take the first stab at the e-learning programme when it comes online, so let us know. I don't think anybody would object. Aaron, you want to say something?
Only reflection, I think that's the importance of, you know, if we look at what we're focusing our attention now on quality and safety improvement and the cultural change that we're looking to enable, this has to be a marker by which we assess whether that's having an impact, a positive impact or not, because this is the lifeblood of our organisation. Having people who are really willing and able to raise issues that require improvement or addressing quickly and effectively through our own systems is part of the way that we have continuous improvement methodologies kind of deployed and taking some confidence in that. It also speaks to another issue, which is what is it? What is the ramification? What is the exposure to risk that colleagues are thinking is going to happen or actually happens as a result of raising concerns? So I'd really like us to hold this agenda close as a board. I'll be doing some work in the interim, but with Bridget when she arrives as the exec lead for Freedom to Speak Up with Heather and Wesley. I've already set up a meeting about, you know, not just freedom to speak up, but incident raising per se and raising issues per se. How do we get a better set of measures or processes that give confidence to teams, not only that when they raise an issue, it's safe to do so, but they get feedback on what the action has been as a result of the issue that they've raised, because I think we're pretty poor in that area. So it's really good for me to get another benchmark. We're a bit static, you know, it's a bit of, you know, despite effort and kind of work that we're putting, it's not moving in the way that we want it to. So I think we need to re-galvanise and double our efforts in this area.
Okay, thank you. Heather, there doesn't seem to be any further comments. Thank you. We know you're busy. Thank you for coming up. And this is an ongoing, as Aaron says, it's ongoing. So I'm sure we'll come back to it. So thank you for the presentation.
Thank you. Thank you, Chair.
Take care, Heather. See you soon. Okay, Kathy, we come over to you then on the research and development update. We've got the paper, we've got the recommendations. Anything you want to bring to our attention?
I guess it was just to highlight really how successful the R&D department has been in regards to COVID-related research, which has generated significant income. The department are now focusing more on their non-COVID projects and starting to get them stood back up as part of the NIHR Managing Recovery Programme. Another positive that came out of all the work they did related to COVID was that they are in a better position now in terms of the estate they have available, the infrastructure to enable them to pick up research projects, which I know they're keen to do. They did enhance their reputation really regionally by undertaking all of that COVID research. And so they are looking to capitalise on that going forward. So I think overall it's really quite a positive picture. There are comments about the fact that the ongoing funding remains under review, certainly from the North West Coast Clinical Research Network. But I think overall a positive picture really.
Yeah, thank you, Kathy. Yeah. Sarah?
Just to note, of course, that I'm here on behalf of Lancaster University, and I know some of that research is done in partnership, and just to say it looks for offers of support. So, of course, the university is here and open to discussion. And I know those links already exist as well through our faculty help. I can help in any way.
Thanks, Sarah. Yeah. Okay, thank you, Kathy. We know the content of your report and the update. We'll come back to it in the board. Okay, thank you. I'll move us back a little bit in the agenda now then. Integrated Care Systems update. Aaron?
Thanks, Chair. It's there for information. There's no decisions to be made for the board. We've got a little bit of time in the part 2 session after lunch where I'll give a further update on provider collaborative board business, but nothing in particular I would highlight for the board at this point. Chair.
Okay, thank you. We note that. We know we received the paper. Okay, closing admin work, there's no item 149. You've got the attendance monitoring register, you've got the schedule of business. There's no urgent business, Paul. I always check with you, no urgent business brought to our attention.
Nothing, Mike. Just to kind of note that in terms of future items that we've highlighted there, that obviously there'll be an update on the CQC improvement plan as well.
Yeah, brilliant. And then I just want to check there, have we covered everything that you feel we need to in the board? We've covered assurance. We've done the 3 A's. Yeah. Okay, then the date and venue of the next meeting is Wednesday, the 24th at 10 a.m. here. I'll close the meeting at 1:15. Thank you.
Thanks, Chair.
Those of you in part 1, we shall reconvene. For part 2, we shall reconvene at 1:35.
Thanks, Chair.
It's like constant mental exercise.
20 minutes.